Hello, everyone, and welcome. We'll start in just a couple of minutes. We're going to give folks a moment to log in. Starting momentarily. Hello, everybody. Welcome. We'll be starting in just a moment. All right. I have a 1:02 Eastern time, so we'll go ahead and get started. Welcome, everyone, and happy Friday to you all. My name is Sabrina Corlett, and I am a research professor and co-director of the Center on Health Insurance Reform at the Georgetown University McCourt School of Public Policy. I'll be your moderator today as we delve into the policy challenges and the opportunities for controlling hospital spending. I'm really excited for this conversation. I think we're going to learn a lot today. I'm also a little sad. This is the final installment of our three-part series on hospital finances. If you missed our first two webinars, be sure to catch up by watching the recordings on our site. We will drop that link into the chat, so you can check that out at your convenience. For those of you not familiar with our center, we are a team of national experts on health insurance. We study the interplay of federal and state policies that affect how people access and use healthcare services. We publish numerous research reports and studies, and we also provide technical assistance to federal and state officials and other healthcare stakeholders. Before we begin, I want to thank the sponsors of today's event, Arnold Ventures, and also go over a few logistics. First, this webinar is being recorded. Everyone will receive an email early next week with a link to the recording, slides, and any resources that we discussed today. The recording and slides will also be posted on our website. Second, this is not a press call, so if there are any members of the media who are on the webinar, please know that all contents of this conversation are off the record. That said, we welcome your presence and feel free to ask any questions. Third, the chat is open now and will remain open, and we encourage you to use it to introduce yourselves, share reactions, and connect. And if you have any technical issues, please drop those into the chat as well, and our producer, Katie Sargent, will do her best to help you. Finally, we have set aside a good amount of time for questions and answers after the presentations from our speakers today. When we get there, we will be taking questions that you submit during the Q&A box at the bottom of the screen. And you can drop those questions into the Q&A box at any time during the webinar. We'll be doing our best to respond to as many questions as we can. Now that we've covered those details, I'm really delighted to introduce today's terrific speakers. We are joined by Kim Cammarata, Assistant Attorney General and Director of the Health Education and Advocacy Unit within the Maryland Office of the Attorney General. Kim is a true advocate for affordable health care in Maryland and works with consumers to navigate health insurance and medical billing issues. We're also joined by my colleague, Christine Monahan, who is an assistant research professor and faculty member at our center. Christine's work focuses on healthcare affordability, including most recently, hospital outpatient facility fees. Finally, we're joined by Tyler Brannen, a senior health economist at BerryDunn, who advises state governments and nonprofits on healthcare financing issues. Tyler has extensive experience helping state agencies, nonprofits, and policymakers understand often complex healthcare financing issues and guiding effective policy. Tyler previously spent 16 years at the New Hampshire Department of Insurance. Now, I'm pretty sure that if you're with us today, it's because you recognize the urgent need to keep healthcare affordable and accessible. And I know that can often feel like a daunting task. Once you start to peel back the layers of our complex healthcare system, it can feel like all you're doing is coming up against roadblocks and dead ends, or simply unearthing more questions. But the good news is that there are some policy options out there that can help shore up people's health and hospital finances. And that's what we're going to talk about today. Our three terrific speakers will walk us through some of the more promising policy solutions out there and really highlight what they could mean for healthcare affordability and access. We'll hear from Kim Cammarata and then Christine about consumer challenges with facility fees and different pathways states can take to address them. Tyler will then take us on a tour of hospital price transparency and other forms of transparency, market oversight, and hospital accountability policies. After we hear from our speakers, we will open it up to your questions, which is always my favorite part of these webinars. We know you have to weigh all possible outcomes in your policymaking. And too often there just isn't the level of transparency around hospital finances that you need to do that well. Our goal today is to have an honest conversation about the benefits and trade-offs of each of these policy solutions. So you know some of the tough questions to ask and you can make more informed decisions about healthcare affordability in your state. Kim, if you're with us, I will let you take it from here. Do we have
Can we go to Christine?
Yes, it sounds like Kim is having some technical issues. So we will have Christine, if you're willing, why don't we kick it off with you?
Sure, happy to take it from here. So as introduced, I'm Christine Monahan. I'm an assistant research professor here at CHIR, and I've been digging into outpatient facility fee billing for the past 18 plus months or so. If we can go to the first slide, or next slide. Thanks. So in prior webinars in this series, Tyler and others have talked about what facility fees are and why we're seeing more of them. And for today, I'm going to jump straight into options for reform. But before we walk through what those might be, it's important to think about what your goals are. In particular, we've identified 3 areas where policymakers can seek to make a difference in the facility fee context. First is consumers' direct financial exposure to facility fee bills in the form of out-of-pocket costs, both because deductibles are increasing and because of how insurer cost sharing typically applies when you have a bill from a hospital in addition to a provider bill. Consumers can end up on the hook for significant and often unaffordable share of the costs of outpatient facility fee bills. The second issue is rising healthcare system costs, which consumers and employers face in the form of premium increases. These come both from the added costs of any given facility charge that an insurer pays for, as well as the fact that hospitals with extensive ownership of outpatient practices generally can increase the rates they charge when negotiating with payers. Finally, there's a lack of transparency around facility fee billing and hospital and health system ownership of outpatient practices, which really gets in the way of both private and public reform efforts. It can be hard to fact-check hospital claims about how devastating reforms would be to their financial viability, as they often claim, when they've got a stranglehold on a lot of the relevant data. So let's look at the first 3 of 6 strategies policymakers can take on the next slide. First up, we have site-neutral payment caps, where you prohibit HOPDs, hospital outpatient departments, from charging facility fees for specified services and cap reimbursement for these services. This has the greatest potential to achieve various goals, but it also is the most politically treacherous, of course, and we currently have very few examples of what these policies would look like on paper, although I hope and expect more may be coming our way soon, both at the state and federal level. Second is where a lot of states, as well as federal policymakers, are looking right now, and that's prohibiting facility fees for a defined set of services, generally those that can be safely and effectively delivered outside of a hospital setting. This comes with the benefit of protecting consumers from out-of-pocket costs associated with the facility fee charge, since that separate bill would go away, but its long-term impact on healthcare costs is likely going to be small because you don't have that cap that a site-neutral payment policy ideally has. So hospitals can seek to recoup any lost revenue in other areas when they renegotiate their contracts. The third option on this page is billing and ownership transparency initiatives. This includes things like a unique NPI requirement where off-campus HOPDs need to register for a location-specific provider identifier and use that on their claims so payers and others can actually see where care is being provided. Ideally, this would be coupled with some sort of system to keep track of which NPIs are affiliated with different hospital systems. With this information, we could see payers try to rein in facility fee charges on their own. Although I'm personally a little bit skeptical of how much kind of the major insurers out there will kind of move this forward just because of market dynamics and some of their own insurer financial incentives, since we have question marks on kind of what sort of impact, real world impact this will have. But it will give policymakers in particular a lot of good information to work with to enact future reforms. Up next on the next slide, we have 3 more strategies. So first is public reporting. And so this is where we talk about states that can require hospitals to report on facility fee billing, including things like volume and revenue of facility fees by service, payer, and location, which can empower policymakers to act down the road, especially if it's coupled with an NPI requirement so that the data they're getting really much more comprehensive and fulsome information. I would also kind of include in this label study bills, which we're seeing a lot of. While annual reporting requirements are going to get you the most consistent information, some states are at least getting authority to do one-off studies about facility fee billing to help inform future reform efforts. And I'll make a plug here for a piece by my colleague Rachel Swindle on our blog about how to make the most out of a study bill if that's where you end up headed. Now, getting into slightly less impactful territory, but still things that might be worth pursuing. States can attempt to protect consumers from out-of-pocket costs associated with facility fee bills by limiting things like balance billing or capping cost sharing, or otherwise limiting how much insurers can pass these costs along to consumers directly. Notably, these types of proposals, unlike a straight facility fee ban, the kind of cost sharing protections are only going to reach state regulated insurance policies under ERISA, where the broader facility fee ban, you're regulating providers. And so you can kind of really reach the whole commercial market. So kind of the just more limited cost sharing protections are more like a Band-Aid option for states. And then finally, we have requirements that healthcare providers and state regulated insurers notify consumers before charging outpatient facility fees. This can increase awareness of facility fee billing and reduce consumer confusion, but we don't really expect there to be significant impacts on consumer behavior or otherwise kind of help shift, lower costs, lower out-of-pocket cost exposure, like some of the other proposals would. So let's go to the last slide, or second to last slide. So I'm not going to run through all of these in the interest of time, but I want to provide some evidence that, outside of site-neutral payment caps, several states have started to take action and adopt these reforms. This isn't a comprehensive list. We'll actually be coming out with a set of maps later this summer, kind of explaining where 50 states are on these types of measures. But if you are interested in learning more about where states are, let us know and we can share more information. And then now to the last slide, I just have some more resources, links where you can follow up to get information I've been talking about, and always feel free to reach out. My email is there, and I will turn things over to Tyler, or if Kim is on, I'll leave it there.
Thanks, Christine. So I'm assuming we don't have Kim yet, so I will begin mine. So as was indicated, this is the third in a series of webinars, and today I'm going to be focusing on the opportunities and challenges for state policymakers, focusing a lot on hospital prices and oversight opportunities. More specifically, these are the areas I'm planning to cover, including hospital prices, transparency, hospital accountability approaches, and then a segment on potential hospital affiliations and oversight of those. So we focus a lot on healthcare prices and hospital prices, and there are good reasons for doing that. If you're not familiar already, these are a couple of groundbreaking articles that really changed, I think, the way a lot of people see the US healthcare system. The question the researchers were attempting to answer was why is the US so much more expensive than other countries? And their research concluded that it's the prices we pay for healthcare services. It was in 2003. They updated the analysis in 2019 and came to the same conclusion. So when we think about healthcare prices and hospital prices more specifically, it's easy to focus on Medicare. It's the elephant in the room for most hospital administrators. Medicare tends to be the most sophisticated payer. They have highly structured reimbursement systems. They don't negotiate with hospitals. They have a lot of work that goes into their reimbursement methodologies. So this basic level, though, there is a question about whether or not the payment levels are adequate. At least according to MedPAC, yes. MedPAC is an independent congressional agency. That being said, you probably run into hospitals that will tell you Medicare doesn't pay their costs. So that raises a kind of a larger question about reimbursement levels. The other thing about reimbursement systems is there's always a question about whether or not the reimbursement rates reflect public policy priorities. For example, over time, there's been a lot more hospital interest in developing cardiac surgery programs than there have mental health service programs. And that has a lot to do with the reimbursement levels for those types of services. A lot of state policymakers will consider the question about whether or not hospital rate regulation is appropriate, at least for commercial insurance. And 30 years ago, there were a number of states that were doing hospital rate regulation, with some success in controlling hospital costs. Today, Maryland still has a rate setting system, and it seems to be working, even to the extent that hospitals in the state generally support that approach. That being said, rate regulation is a bit of a lightning rod for a lot of state legislators. It's true at the federal level as well. Legislators that would rather see sort of our problem with costs solved through some sort of market type approach that doesn't rely on a government entity setting rates for hospitals. So certainly it is an option that does seem to be working in Maryland, but if you're going to approach that, certainly do your homework and do so cautiously. At the end of the day, though, whether we're talking about Medicare's reimbursement systems, a rate setting, or what our insurers are doing, there is a question about who is going to be that rational consumer, the rational consumer that's going to consider compromises, choices, and really even decide whether or not the price for healthcare is worth paying. And is that going to be the government? Is it going to be our insurance company? Or is it going to be the individual who has really high cost sharing? An individual rarely feels empowered, they really feel knowledgeable, so that can be a very tough place to be. It does lend itself to a question, though, about hospital price transparency. And this is an area where I've spent a fair amount of my career. I was hired by the New Hampshire Insurance Department in 2006, and the first major project I was to work on was to make use of our brand new all-payer claims database to put together a health cost website that would be designed for consumers and show consumers the price of healthcare services. We use those claims data to look at the allowed amounts that were paid to hospitals and other providers, the allowed amount being the price of healthcare services, including what the insurer would pay, and any patient liabilities like deductibles or coinsurance. So we were using data that was incredibly detailed at the payer and at the provider level. And because it was for consumers, we ended up bundling the services together, because you could see for a knee surgery that an anesthesiologist was involved, that there was going to be a facility claim. Most patients didn't understand that there'd be different providers involved. So we were able to bundle those claims together and produce a price that was specific to a hospital and for an insurance company. What the insurance department was doing was considered highly controversial at the time. Before we put up the website, One of our major payers went to our attorney general to try and get them to stop us at the insurance department from doing it, making the argument that we're going to be releasing proprietary information and all sorts of bad things would happen. Other insurers approached the department with similar arguments, and we obviously heard from hospitals and some other providers that were also concerned about us releasing proprietary information. However, once the website was up, there was a bit of a turn. People were generally supportive of the methodology we used, and we even had one of the major insurers come to us, gee, we were worried about this because we were worried that people would see we had the best deals. Now we can see from the website we don't, and that gives us a chance to go back and work on what we're doing. Hospitals that were worried about being the most expensive in the state found out they weren't. And people tended to appreciate how much price variation there was when we actually put the data up. APCDs were seen as a major asset across the country. I spoke to a number of different states that wanted to set up something similar to health cost. And of course, it took steps to work on an APCD first. Today, about half the states actually have one in place, and many of them may not realize it, but part of the motivation was because of New Hampshire health cost. Several years after we put up the website, though, we didn't know if that was an effort that was worth continuing. We were going to put some investment into it, and we were talking to the carriers because they had their own tools. And we asked, do you think we need to keep this going? Should we make those types of investments? And all the insurance companies said to us, yes, please do. You're doing it better than we are. You can put actual prices in the public domain. And now there's increased sensitivity to how much price variation exists, which allowed them to start to modify their benefit designs with incentives to go to lower cost providers. So this is a long way of saying that essentially, even though it was controversial at first, there was a move and there was more receptivity to it later. I wouldn't say any of those parties are fans of price transparency, but they have come around and generally supported New Hampshire's effort. Both before and after health costs went up, there was a lot of legislation that was introduced that would have required healthcare providers to post their prices or their costs or their charges. There was a lot of confusion about what it was that they were supposed to post. And even in a state like New Hampshire, it would have meant thousands of providers putting up this kind of information. But instead, those parties turned to the legislature and said, there's no reason for this bill because the insurance department, as a neutral party, is putting up information that's comparable and answers a lot of the questions that people would have about prices. It is worth recognizing that there were some hospital and private payer voluntary efforts. Private insurers were trying to tell their members where to go without telling them exactly the prices they were reimbursing providers at. There were some hospital efforts, but they were done real inconsistently. I can remember one example where a hospital had posted a price of a mammogram, but they were just showing the technical component for that mammogram. So what the hospital would be paid, not what the radiologist would be paid for reading the mammogram, which obviously is important to people. So we didn't put up the website to save money. That wasn't really a goal with it. At the time, cost sharing was relatively low, so many people would hit sort of their $500 deductible before they paid anything. But there was a lot of interest, particularly among the legislators that were supporting development of an APCD for people to know how much something would cost. That being said, there has been research on the New Hampshire experiment that did show that there were savings. For the radiology services, the researcher concluded that there was about a 3% savings. It was larger, though, for the people's cost sharing, from about 5 to 11% over time. In contrast, the CBO is suggesting that the savings, according to price transparency, would be much more modest and less than 1%. So it's certainly worth understanding some of the limitations in terms of savings associated with price transparency. Today, there are federal requirements for both hospitals and insurance companies. There are consumer-facing tools, but there also is a lot of interest in emphasis on machine-readable files. These are incredibly large data sets that do have prices paid, but they differ depending on the insurance, the product, and a number of other things. There have been concerns about the quality of those data, as well as the applicability. Consumers can't use those data sets directly, but they do lend itself for vendors who are used to working with very large, very technical databases to make use of it and perhaps design consumer tools. One of the disadvantages with claims data is that it's always a little bit old. So we updated the health cost website pretty often. Actually, when it first went up, it was on a quarterly basis. And the data were, maybe 6 months old, but you had to go back further than that to actually calculate the rates. So you're dealing with data that, at best case scenario, it's about a year old. You can put an inflator on it, but it's always still a little bit of a lag. Whereas these pricing transparency files, they should be current and updated much more frequently. The advantage of the claims data, though, is it tells you what kinds of services people are actually getting and what other services are done at the same time. Pricing files won't give you that, but they do have the current information. So maybe having some combination of understanding what utilization is taking place with current pricing, and maybe that's an opportunity for the future. There are a number of state opportunities for hospital accountability, and those that are focusing on the cost of hospital care can include state health policy commissions and affordability boards. There's some great examples of those across the country. It could also include certificate of need. So there are still a lot of states that have certificate of need, although some have done away with it. This is a process where an entity reviews applications from hospitals and other providers before they make major investments. Could be a new building or a new wing, could be an expensive piece of technology. And certificate of need typically has a focus on cost as well. So that might be another area where sort of considerations for hospital costs could be addressed, perhaps even more effectively. I would recommend that we continue down the road of improving price transparency. There are also opportunities when it comes to the hospital financial statements. The audited financials are considered the gold standard that's out there, but not all states require them to be public. There are some inconsistencies. Sometimes they're done at the system level, sometimes they're done at the hospital level. They don't include information like payer mix or the size of the hospital. So there certainly is opportunity in getting that kind of information more available to the public. And ownership is another area that would benefit from some additional transparency. There's been a lot of interest in private equity lately and its investment in our healthcare system, but it's very difficult to understand exactly how often private equity is involved because of complications in determining sort of the ownership and the investors. So certainly that's an area of opportunity, and some states are exploring that already. Another area that I do recommend that perhaps doesn't show up on the radars often is modifying hospital reimbursement through state insurance laws. So insurance is regulated at the state level, even with the ACA and other federal laws. State legislators have flexibility to incorporate new changes as it relates to commercial insurance. And we think about how commercial insurance companies are negotiating with hospitals and paying what is now more than 2.5 times the average amount for Medicare. Certainly, there seems to be some opportunity there. In my home state of New Hampshire, we actually have a section of our insurance statutes that's called provider contract standards. And in there are requirements for the contracts between an insurance company and a healthcare provider. Rhode Island, though, seems to have set the benchmark. Over 10 years ago, they actually put in price increase caps for hospital services and addressed the underlying reimbursement methodology, and also required an investment in primary care. And recent research is showing that this approach is working. There are actually savings associated with the approach. When we think about insurance laws, it's important, though, to think about consumer protections and how they may be influencing the hospital prices. One example of that is network adequacy requirements. So these are requirements that carriers need to meet to ensure that people have reasonable access to healthcare providers performing services where people buy their insurance. A lot of states are relying on the federal time and distance standards for network adequacy, but there's still a fair amount of flexibility at the state level. And if states raise the bar for network adequacy so high, in other words, set the standards so high that a consumer is greatly protected, they can also create kind of a monopoly situation with a local hospital. So in other words, the insurance company needs that hospital to meet network adequacy standards, which gives that hospital a fair amount of bargaining power in the negotiation, bargaining power that can result in higher prices. Certainly, if you've got some sort of price cap or increase cap like Rhode Island, then perhaps you're in a better position to increase those network adequacy requirements. But in most cases, you have to kind of be careful and look for a balance. One other area that's worth mentioning that is not purely commercial insurance is what's going on with state employees. So legislatures are often concerned about the cost of the coverage for state employees, which is obviously a large population that the state is responsible for. There often are discussions about how robust those benefits are, but one of the other opportunities is to think about how hospitals are paid for services provided to this covered population. And indeed, Montana has actually implemented a reference pricing model that is based on Medicare, and there are savings associated with that. I would exercise, though, a fair amount of caution with approaches when you're dealing with the state employee population and legislation on that front. It can be a little bit difficult to work through some of the politics. State oversight of affiliation reviews, and this is an area I've actually spent a number of years working on as well. It's considered a great area to deal with hospital prices, mostly in light of the fact that as we see increased consolidation, increased hospital mergers, we're seeing higher prices paid for those services under those merged entities. So over a 10-year period, according to recent research, only about 5% of those transactions were actually challenged. When they were challenged, they were in states with robust merger review authority. So when we think about challenging some of these transactions, there is a lot of interest and focus on states' attorney generals and the antitrust laws, which is a great place to start. But I would also encourage you not to forget about a number of other laws that apply to these transactions or may apply to these transactions. Charitable trust is a great example of the types of laws that do apply and consider whether or not the transaction is good for the community. It also may consider a component based on cost. Nonprofit corporation, health safety, and then of course CON are also areas that may be involved in reviewing transactions. When the transactions include hospitals, that's pretty straightforward, but it's also important to look at whether or not the entities controlled or owned by hospitals are part of the transaction. That's an important part of that sort of bargaining power between hospital systems and insurance companies as well. But ultimately, any of these transactions should be in the interest of the public. And there are a number of ways of approaching that. One of the other key things that is important for these reviews is for the reviewer organization, whether it be the AG or another entity, to impose conditions on the transaction if it moves forward, ideally outside of the court system. A lot of AGs are comfortable putting forward a consent decree and working through that agreement. Others would consider it like an administrative burden. Litigation is clearly not the best solution in most cases. But the ability to impose conditions is important and hugely helpful when you're looking at a transaction. The other thing to remember about kind of the proposals that are put forward, whether it be an affiliation agreement or something else, is these are separate parties until they move forward with all the integration, which means they can't discuss everything. They put together business plans, but they have to be careful about violating antitrust laws because they're still separate organizations. So that review process and conditions can play a key role. The other thing about reviewing these types of transactions is to consider at what point the reviewing entity knows about them. So typically there's a dollar threshold that unless it's exceeded, there's no requirement to apply for sort of an approval or something else. You can lower that dollar threshold so at least the state entity knows about it. Clearly, you don't want to create a requirement for the state entity to review everything, but that could be burdensome. But they have to know about some of these transactions, particularly over time where the accumulated value could be quite high. These are some examples of conditions related to a merger that deal with kind of costs and potentially pricing. You can impose conditions in a number of different areas, including the requirement to address community needs and things like mental health, SUD treatment, even maternity care. But these are examples that do address kind of prohibitions that if they're not already in state law, could help to address the transaction and potential repercussions of higher prices. Ideally, you would get concessions about the prices from the parties that are coming together. However, those types of concessions on a future basis are very difficult to obtain. They're also difficult to measure and enforce over time. So in summary, healthcare costs are largely driven by prices in the US when we compare that to other systems. And there are also questions about how our resources are allocated and what incentives exist. Transparency in the health system is improving, but there are a lot of opportunities. And then finally, state agencies can absolutely play a role in addressing hospital prices, but they need to be empowered and they need to have the right tools. At this point, back to you, Sabrina.
Great, thank you, Tyler. And I have some good news. The gremlins that were in Kim's Zoom app are still there, but she was able to dial in via phone. So Kim, do we have you on the phone?
I think so. Do you hear me?
I sure do. Yes. Thank you so much for persevering. We're going to go back to the discussion of facility fees that we started the webinar with, and turn to Kim Cammarata, who, as I mentioned, is with the Attorney General's office in Maryland and been doing a lot of work with respect to some of the concerns about facility fees. So Kim, take it away.
Thank you, guys. And, again, forgive the gremlins. It was not much fun, but, it is what it is. So hello, everyone. As mentioned, I actually run the Health Education and Advocacy Unit, which is an advocacy unit within the Maryland Office of the Attorney General's Consumer Protection Division. And we assist consumers with a variety of disputes in the healthcare marketplace for lots of reasons. But one of our sort of legislative mandates is to identify and make recommendations for measures that protect the interests of healthcare consumers based on the work that we do. And we first started reporting about unexpected facility fees to the General Assembly in 2016. At the time, many of the complaints that we were receiving from patients were from patients whose provider practices were acquired by hospitals, and the hospitals sought authority from Maryland's Health Services Cost Review Commission to have the acquired practices be deemed at the hospital, allowing the hospital to bill for the use of the facility to perform the services at a rate set by our Health Services Cost Review Commission. I should note that Maryland has a unique payment model with CMS. It's an all-payer global budget model, and that in Maryland, our Health Services Cost Review Commission actually sets hospital rates. But for those patients that reached out to us, their routine yearly visits to their eye doctor, for example, now came with a provider bill and an entirely unexpected hospital bill. One patient went in for a routine eye exam, and for the first time, in addition to getting his bill from his provider, received a fee bill. Another MS patient reported newly facing a $1,500 facility fee bill for her yearly neurology visit. Another patient reported newly facing a $1,700 facility fee for his annual visit with his rheumatologist. So as more of these complaints came in during our mediation of these disputes, we started asking the hospitals what, if any, notice was given to these consumers about these unexpected fees, and found really that little, if any, notice was provided beyond vague signage, which was in the office, so the patient's already there, or through some pre-appointment confirmation notices that the consumers might receive two bills, but with no information about what the cost would be. We also found that consumers weren't being told when they could see the same provider for the same service at a facility fee-free location. So in 2019, a lot of states hadn't done any work in this space, but Connecticut had, and we sort of used Connecticut as a guidepost and sought legislation that would require specific pre-treatment notices about outpatient facility fees. There was significant pushback from the Maryland Hospital Association, largely related to the cost of providing the notice, the details of the notice, the scope of the notice, and arguments that consumers would choose to forego needed care if they received a notice that warned them how much the care would actually cost them. MHA also argued that consumers face the increased cost not because of the fee itself, but because of the increase in high deductible plans and carrier models increasing cost share for hospital-based services. Finally, they argued that the fees were necessary to ensure that the community had 24/7 access to care. Unfortunately, in 2019, our legislation did not pass, but the large fees and the stories that the many consumers who testified before the General Assembly really resonated, and the General Assembly asked for an interim briefing on the issue, and also asked the HSCRC to look at some of those E&M service costs, the $1,700 bill for the routine eye exam, and that actually resulted in our Health Services Cost Review Commission reducing some of those E&M services, but in a budget neutral way. Following that briefing in 2020, we came back to the General Assembly with the same legislative proposal, which was nearly over the finish line, when in the waning hours of a COVID-shortened session, the definition of outpatient services in the bill was amended to include only clinic services, which significantly reduced the number of consumers that would be entitled to that statutory notice. We did, however, have a law, and so outpatient clinic patients are required to be provided very specific pre-treatment, oral and written notice about the facility fee, along with the actual fee or an estimate and range of the fees. And if there is a facility fee location available, that they can see the same provider in a fee-free location. And then some other things about financial assistance and to check with your insurance carrier about your your real out-of-pocket costs. Then Georgetown and others started studying this issue in earnest, and armed with that national attention, Georgetown support, continuing consumer complaints, and our Attorney General's testimony, we tried again this last legislative session to expand the definition of outpatient services beyond clinic services. And we also put study language in the bill to ask the Health Services Cost Review Commission, in consultation with the various stakeholders, to really study the issue, study lots of the factors that I'm assuming Tyler talked about while I was dealing with gremlins, and make recommendations about how we should really deal with facility fees here in Maryland. We were disappointed when our efforts to expand the notice beyond clinic services failed, but our Health Services Cost Review Commission is going to be studying the really important factors necessary to truly understand the impact of the fees in Maryland's healthcare marketplace. And we're hoping that study and programs like this will provide information necessary to inform policy both nationally and perhaps in your states. So thank you for asking me to join you. And that's sort of a really quick overview of sort of where we were in Maryland.
Thank you, Kim. That was great and really helpful. And I appreciate your flexibility in jumping here at the end. All of our panelists provided some great information. We're going to now dive into questions and answers. So please put any questions you have in the Q&A box, which is at the bottom of your screen. I'll kick things off with a question of my own, and I'd like to ask this of all three of you if I can. We've talked through a number of different options today, from facility fees to hospital oversight, price transparency. It's a little bit overwhelming. Where should lawmakers start? What's the first thing that they should know, or what would best set them up for success when it comes to these issues? Christine, maybe I'll start with you.
Sure. I mean, I think I'd go back to where I started, which is first you want to figure out what your priorities are. Are you most concerned about kind of consumers being hit with kind of out-of-pocket costs? Are you concerned about how rising prices and costs are affecting employers and payers and others in your state? That will help you figure out there's a lot of options on the table. And so to pick and figure out which one makes the most sense for you to kind of put your time and energy in. And related to that, I would, think about, okay, here's ideally where I would like to see this proposal go. But as Kim's comments make clear, this is an incremental process. And so I think I'd also be prepared with, okay, here's where we're going to start. In reality, though, in our back pocket, here's kind of the scaled down versions that we think would be most effective.
Tyler?
Yeah, I similarly think that kind of the practical approach is a good place to start, which includes first understanding what your state has already attempted to do, understand what data are available so that you understand the environment. The number of sort of policy efforts or legislation I've seen introduced that really didn't have that background, and the response is kind of like, well, didn't we try that already? Or what's different about this approach? And did you know about this that we've already implemented something new? That being said, I still think there's a lot of benefit that comes from focusing on what we're paying for care, whether it be prices through price transparency. The facility billing is another fantastic area, but you also need a champion, somebody who's going to dedicate the time, and hopefully it's more than one legislator, to see it through. A lot of these bills, particularly ones that will result in lower payments to providers, won't pass. They'll end up in a study committee or a study commission, and somebody needs to continue with it for at least another year before it comes back. One of the best examples I saw of kind of this process working was when New Hampshire passed surprise billing protection several years before the federal government. And it did. It took a lot of introductions, a lot of ideas, a study committee that focused and was driven forward. And then we came back with a bill that addressed at least many of the concerns. And we limited it to a certain number of providers, so 4 different specialties that was included. And that was a bit of a success story, at least from a consumer protection point of view. But it did obviously result in lower payments to some providers, at least in some respects. So I think that focusing on the prices, the facility billing opportunities, I think, are another very similar example of where if there's enough interest, enough motivation, you can make some progress. You can protect consumers, not just from the upward pressure on premiums associated with the higher prices, but some of the cost sharing. One of the first examples we had to address was higher cost sharing at urgent care center because the organization was billing with the hospital claim using a 450 an emergency department code, which triggered emergency department cost sharing. So it's certainly there is opportunity on a number of fronts, but I would focus on kind of that facility billing and prices and really what your state has done already.
Great, thank you, Tyler. And Kim.
Yeah, and you know, because Maryland has a unique payment model, we really couldn't just mirror what other states were doing. And so I suspect, of course, other states have unique differences that need to be considered as well. So, you know, I guess my recommendation would be for policymakers to start kind of where we ended up, which is really to, at least with respect to facility fees, let's ensure that these consumers have adequate notice while we really do have a study and to study what the impact of those facility fees is on the marketplace, right? I mean, on, as you said, Christine, on the employers, you know, and other payers, on the consumer. But we really need to sort of study the issue a little bit better rather than sort of what we just sort of came in. We were really most concerned about, look, while we study this, while we look at this, consumers need to have notice. So, but then doing the work, doing the heavy lifting and really studying the data.
Great, thanks. So I'm turning now to the questions that are going into the Q&A box. And just a reminder, if you have any questions, please enter those into the Q&A box at the bottom of your screen. So the first question, I think it originally was related to the presentation on facility fees, but I think it may have sort of a broader application, and it's about the impact of some of these policies on employers as healthcare purchasers. So Christine, I'll start with you just because I think this question was related to your facility fee presentation, but I'd be curious too, Tyler, if you know, you have thoughts on how, whether it's price transparency or some of the oversight of transactions, how that might impact or affect employers as healthcare purchasers. So Christine.
Sure. And I should have perhaps been more precise with my slides and my language, but I do think with kind of the second goal that we describe and that I talked about, you know, we're looking at reducing healthcare spending, which then can drive down prices and drive down how much ultimately payers are paying for care, including employers and other purchasers. And so I think there's huge benefits for employers from these sorts of reforms, be it facility fee reforms that are directed at trying to lower total spending and other cost containment initiatives. And you see employers increasingly, you know, being some of the leading supporters of these proposals. In Indiana, it was kind of the employer groups there, including the Indiana Manufacturers Association, who kind of identified, hey, we're spending a ton of money and we don't necessarily think all of this money that we're going out the door is appropriate. And so they've been driving forward and saying like, okay, let's limit, you know, facility fee billing in certain circumstances, and let's get more transparency about our healthcare spending overall. I think there's a lot that can, you know, employers have at stake. They're covering a huge swath of our population. They are some of the biggest spenders when it comes to healthcare dollars. And so they really, they should be paying attention to this. It has huge benefits for them.
I would say anything an employer can do to participate in the legislative process when there are bills brought forward that are dealing with spending concerns is beneficial. And I think that there is sometimes a can serve as a distraction when employers are looking for opportunities associated with meals or purchasing alliances. In other words, the only way they're going to get the savings they might be looking for is to end up with a more favorable risk pool. And that's generally not something that works within the smaller employer market where often we see that kind of interest. But to the extent the legislature is going to be responsive to concerns about prices, hearing from employers directly about what they're facing, what limitations they have in terms of choice of products, their ability to create friction with their actual employees, that kind of message can be heard and certainly delivered in an effective way that's beyond, I think, what sort of representation for employers can do. So certainly play a role, get out there, express your concerns, and focus on that emphasis around the cost of care being simply too high.
Great, thank you. I think this next question might be best directed to Kim. And this is, how would you respond to pushback from hospitals and health systems that argue facility fees are essential to cover costs and are necessary to keep hospitals, particularly rural facilities, from closing down?
Yeah, and I mean, of course, those arguments were made, and that is why there's going to be a study, right? We didn't do a deep dive in looking at the data and looking at the numbers, and when we were sort of faced with some arguments about numbers that if particularly, well, I'm trying to sort of thinking out loud here. I don't do that very well. So again, we have to really look at the numbers and what we weren't hearing from hospitals was about the numbers. It was just an argument that was being made. And so when we asked for, we asked for figures, we asked for data, we weren't getting the data. So that's why the data is now really going to be studied.
Great, thank you. Christine, I don't know if you'd have anything to add to that.
Yeah, I mean, I think not all hospitals are going to be in the same financial position. And I think the hospital industry is going to be inclined to highlight the most vulnerable hospitals in policy discussions and have that kind of lead the narrative, but try to say like, okay, well, these hospitals are in perilous position, so none of us should be regulated. And so question A, like, does that really make sense? I mean, other hospitals are doing a lot better. Also, is it true? As Kim was saying, like, let's see the data. Let's like actually parse this out and get a better understanding of what's happening. And, it might be the case that they're talking about all, the risks of rural hospitals. Well, do we know are rural hospitals actually, taking in a lot of revenue from outpatient facility fees? Maybe they're not. And if they are, that is like the make or break difference for a rural hospital. I mean, is the reason that hospital is in some peril because they can't charge $1,000 for an outpatient facility fee for a visit that costs $200? That's probably not actually what's driving it. It's other issues, and we can think about if we actually get to look at the financials and see what's happening, figure out, okay, what is actually the problem here, and come up with more targeted solutions to help the hospitals that need it without, reinforcing a payment structure that does not make sense and that's not rational in terms of, what we're paying for in different circumstances.
Thank you. Unfortunately, we looks like we only have time for one more question, and it actually came in through the chat, and I apologize if I mangle your name, but it's from Delegate Srinivasa from Virginia. And this is a question for Tyler. He's curious if you could share a little bit more about what you were doing in New Hampshire and Rhode Island to work through commercial insurance to reduce hospital costs.
So for clarification, I left the New Hampshire Insurance Department a couple of years ago. So any work I'd be doing in New Hampshire would be separate. And as it relates to hospital costs, I would say most of the work I'm involved with is dealing with potential transactions. And there are a number of different approaches. As I mentioned, it's difficult to get sort of price concessions as a condition when entities come together. But one of the biggest advantages, I think, is that you can impose conditions, and it doesn't just apply to the sort of the entity that's being acquired, being merged into a larger system. Those conditions can apply to all the parts of that system that are involved. And it can include anything from data being collected. In other words, as a part of the antitrust review, it's important to know which physicians are employed by a hospital. But New Hampshire is an APCD. Hospitals tend to be self-insured. Perhaps having those claims as a part of the public price transparency effort is something of value. So a better understanding of the costs of what's going on in New Hampshire is some of the steps that are going forward. There are also a number of those types of conditions. They have ended up in court orders that are part of a transaction. That's public information. So I think probably looking at what's taking place on the transaction front is one of the more interesting areas, at least that I'm involved with directly. Certainly the legislature is looking at things like what's going on with ambulance balance billing and other areas that are quite specific. But we did actually have a bill a number of years ago that would have prohibited any facility billing off the hospital campus. Unfortunately, it did not move forward, and it is one that was turned into a study committee.
Great, thank you. I'm afraid we're going to have to conclude the questions there. I hope you all have learned today as much as I did. Thank you again to Christine and Tyler and Kim. We couldn't have had this conversation without your wisdom and expertise. And thank you to all of the speakers who have made this webinar series a success. You can find all of the recordings on our website. Please also sign up for our newsletter so you can learn more about future events and webinars that we are planning, and we're going to be dropping some of those links into the chat. Before you sign off, please take a moment to fill out the very short survey that will pop up on your screen. We really take that feedback seriously and use it to inform the programming of future webinars. Thank you again. Have a wonderful weekend and be well.